Welcome to tonight's webinar, Treatment Options for BPH Enlarged Prostate, presented by Dr. Matthew Steinway. Dr. Steinway is a board-certified urologist with Arizona Urology Specialists. He also serves as a clinical assistant professor at the University of Arizona College of Medicine, Phoenix, and has served as Chief of Urology, Banner University Medical Center, Phoenix. His areas of clinical specialty include the care and treatment of prostate disorders such as BPH, enlarged prostate, including minimally invasive surgery. He sees patients at the Arizona Urology Specialist office located at North 73rd Street in Scottsdale. Welcome, Dr. Steinway.
Thank you, Jennifer, for the introduction. We're going to be talking about BPH, or benign prostatic hyperplasia, tonight. Little disclaimer here. As Jennifer mentioned, I am a urologist at one of the two Scottsdale locations for Arizona Urology Specialists. Among many things, BPH is one of my interests, as you can see listed here. So tonight we're going to be talking about the prostate. We're going to be talking about what the prostate is, what it's there for, some issues that arise related to the prostate, and more specifically, talking about BPH, benign prostatic hyperplasia, as well as treatment options associated with BPH. We'll start with an overview of the prostate. So what is the prostate? Prostate is a gland that sits at the base of the male bladder. The urethra runs directly through the prostate as urine exits from the bladder outward. The prostate's involved in fertility, in producing fluid that helps to transport the sperm during ejaculation. It tends to mature as men grow into their 20s. And then when men reach their 40s and 50s, it tends to grow again. And that's what leads to some of the issues that we'll discuss tonight. So things that we see happen with the prostate, of course, we're talking tonight about enlarged prostate, or BPH, but also some men will have infections or inflammation of the prostate, also called prostatitis. And of course, prostate cancer is something that is relevant and something that is important for us to be able to monitor in patients. So now talking more specifically about BPH. BPH is a benign or a non-cancerous hyperplasia or growth of the prostate. We see it in men as we age. And the issue with BPH is that as the prostate enlarges, it can lead to an obstruction of the bladder outlet, or as the bladder drains, and that can lead to significant urinary tract symptoms. There's really not much of a link between BPH and prostate cancer. BPH is not prostate cancer itself. It doesn't cause prostate cancer. Some of the symptoms can mimic one another, and some men will have both BPH and prostate cancer. PSA is a blood test that we use to screen for and follow men with prostate cancer. But PSA alone does not distinguish between BPH and prostate cancer. Interestingly, both BPH and prostate cancer can be associated with elevated PSA levels. So this can be important in terms of the evaluation for men with urinary symptoms. So I've got two pictures here, one of normal and one of an enlarged prostate. And you can hopefully see that as the urethra runs through the prostate in a normal prostate, there's a nice wide open channel. However, as the prostate enlarges, it can cause a blockage or obstruction there that can lead to backup of the bladder and retention of urine. The overall size of the prostate doesn't necessarily correlate with the degree of obstruction or the severity of the symptoms. You can have someone with a minimally enlarged prostate that has significant symptoms, and we see men with very large prostates that have minimal symptoms. So it's very important for us to put the whole picture together when we're evaluating men to see what's appropriate treatment for them. So the symptoms of BPH, I know I've mentioned urinary tract symptoms. This would include things like urinary frequency, either during the day or nighttime, a sudden urge to urinate, burning or discomfort with urination, weak stream, the feeling like you're not emptying your bladder completely, trouble starting and stopping or hesitancy of the urine stream, and even the inability to urinate or urinary retention, possibly even requiring a catheter. BPH affects men's quality of life. 95% of men in one study with moderate symptoms were unhappy and didn't want to spend the rest of their life this way in terms of their urinary symptoms. Half of men reported that it interferes with normal daytime life activities. Another half of men say that their urinary symptoms are associated with sexual dysfunction. This also impacts men's partners, affecting their quality of life, affecting their relationships as well. So who gets BPH? Well, it's a very common issue that we see in men above the age of 50. In fact, half of men by the age of 60 have some symptoms, and 90% of men by the age of 85. So this is a very common issue that we see in men with aging. 10 years ago, it was estimated that 14 million men in the United States had lower urinary tract symptoms related to BPH. That number has probably increased over the last 10 years given the aging of the population. Other things that may increase the risk of BPH include obesity with a body mass index that's higher, as well as lack of exercise. So, how do we diagnose an enlarged prostate? First, you would typically come to the office, or at least for now, we're doing visits on telehealth to get a history and understand more about what the symptoms are. Sometimes we'll use surveys such as the AUA symptom index or the IPSS scores to assess your symptoms and give an objective evaluation. A physical exam is also important, examining the prostate with a digital rectal exam to estimate the size of the prostate as well as to identify any abnormal nodules or anything suspicious for cancer, as that's part of the evaluation. We also will often do urinary testing, whether it's with a urinary flow test and or a post-void residual, typically done with a bladder ultrasound, where we can measure the amount of urine left in your bladder after you urinate. There are other parts of the evaluation that we may do, including checking PSA, performing a cystoscopy to evaluate the anatomy of the urethra, prostate, and bladder, and sometimes an ultrasound to measure the volume of the prostate, as that can be helpful to determine which treatment may be appropriate for a patient. So I've alluded to some of the treatment options, so we'll start to go through from the least invasive to the most invasive. On the left, you can see the least invasive options: behavioral modification, changes in fluid or diet, certain things that may be irritants to the bladder that we try to avoid. Watchful waiting, meaning the symptoms are just mild. We're just going to keep an eye on things, and it's not worth some of the potential side effects or risks of the medications or procedures that we'll talk about. And there are some other things like physical therapy, Kegel exercises, bladder retraining, things like that. When those don't work or when men aren't happy with their symptoms, then we move on typically to first-line therapies. That can include medications, which we'll get into, or some of the minimally invasive procedures that we'll also discuss later. And as we increase the level of invasiveness, you'll see toward the right, there's surgeries such as green light laser or TURP, or even surgery with prostatectomy to actually make an incision and remove a portion of the prostate. Just a quick side note, because this gets asked a lot by my patients in terms of additional vitamins or supplements that may have some benefit. There's really been nothing in the literature to support the use of some of these things, including saw palmetto, which comes up often. However, I have a number of patients that take these, and if they feel like it's helping them, I think the risk is very low, but the benefit is not quite understood. So getting back to the treatment scale from least invasive, we talked about watchful waiting. So lifestyle modification, including adjusting diet or decreasing the fluid in the evening times to reduce the nighttime urination, adjusting when medications are taken. So not taking a diuretic at night before bedtime, so you're not awake at night with producing urine. About a fifth of men are okay with this. 19% in one study were satisfied with some of these changes. Obviously, there's minimal risk in terms of this, other than the symptoms may progress, and we may then need to discuss some of these interventions that we'll talk about next. There are several medication options that we have for treatment of BPH. The most common first line would be an alpha blocker. This would be something like tamsulosin or Flomax, Rapaflo, Uroxetrol are all commonly used ones. It works by relaxing the muscles in the bladder and the prostate, and that allows the urine to flow better. It allows the stream to improve and men to empty their bladder better. There's pretty minimal side effects with these medications. Some men will notice some dizziness or lightheadedness, rarely fainting, and rarely interactions with other medications. The reality is that more than half of men stop taking their medications after a year, either due to the side effects or just due to not wanting to take a medication every day. Obviously, there's no anesthesia or surgery involved with that, so there's minimal risk in that regard. Another class of medications we use for BPH are 5-alpha reductase inhibitors, things like finasteride or dutasteride or Avodart. Those are medications that actually help to stop the growth or actually shrink the prostate. It works by lowering the hormone DHT, which is a very concentrated form of testosterone within the prostate. Typically, it works over about a 4 to 6 month period, so it takes a little bit longer for it to take effect compared to the alpha blockers that are quicker acting. These have a slightly different side effect profile than the alpha blockers, sometimes can lead to more sexual side effects, such as erectile dysfunction or ejaculatory dysfunction. It can also be relevant in men that have issues with PSA and can affect how we follow PSA, as it can falsely lower that number by about 50% once they've been on it for long enough. So it's important for the urologist to know when men are on these medications and to account for that. Another class of medication I don't have a slide to discuss are the PDE5 inhibitors, or Cialis or tadalafil is the generic. This is something that's being used more commonly now for men with lower urinary tract symptoms due to BPH. Traditionally, that was used for erectile dysfunction, but we are seeing some benefit in terms of its use for men with enlarged prostate. Moving on to the minimally invasive procedure, still within the first line therapy, one example is Rezum, or water vapor therapy. So it's a procedure typically that we do as an outpatient in the office, where we inject water vapor or steam into the prostate that causes the tissue to shrink and for that channel of the prostatic urethra to open up. Typically, it's done with a local block without any general anesthetic. There's no implant that's used. And the surgical retreatment rate of 4% after 5 years is quite excellent, as I'll show you compared to some of the other procedures. Of course, with any procedure, there are side effects and risks. Specifically for Rezum, in the short term, most men have some degree of urinary frequency, some urgency, maybe a little discomfort with urination, and then it's normal to have a little bit of blood in the urine or semen for the short term. Here's a diagram here at the top showing a before versus an after. And the growth of the prostate here causing the obstruction of the urethra, it would be the area that's treated by the Rezum. And then usually 1 to 3 months later, this is what it would theoretically look like with a nice wide open urethra. One study showed that 97% of men would recommend it to a friend. And I've actually had a number of patients who have referred their friends after having this Rezum procedure done. So it's been a good source of referral pattern for me in my practice. Another minimally invasive procedure that we are using more and more is prostatic urethral lift, or Urolift is the brand name. It's also an outpatient procedure where implants are placed within the prostatic urethra to open up that channel and hold it with little implants, little anchor devices that cinch open that prostatic urethra and allow for a nicely wide patent prostatic urethra. It can be done under local or under a light anesthetic. Typically does not require a catheter. It does require permanent implants of these anchor devices, and the surgical retreatment rate is actually quite good as well after 5 years. Of course, like with any procedure that we do on the urethra, some men will have some discomfort with urination, blood in the urine, and rarely for this procedure do we see things like stones or pelvic pain form. As we move into the more invasive portion, or more invasive options of treatment for BPH, we look at TURP, or transurethral resection of the prostate. This is considered to be the gold standard. It's been around for decades, but as technology has improved, we've seen improvement with the procedure itself. It's also typically done as an outpatient procedure. Rarely would a man need to stay overnight after this procedure. And it uses electrocautery to cut the tissue from the prostate and actually remove the tissue. The newer devices use a bipolar technology, so the risk of bleeding is minimal. And some of the side effects that existed in the past with the old systems don't exist anymore because we can use saline as a resection fluid, as opposed to some of the older technologies where we had to use other irrigation fluids that could lead to other problems. It does require a general anesthetic, and the surgical retreatment rate, again, right around 5% after 5 years. Like with all these procedures, some pain, discomfort for the temporary first few weeks or so, blood in the urine, and infection retention is a risk, although low. Green light laser therapy is another energy source that we can use to accomplish a very similar result of the TURP. This actually uses a laser energy to vaporize the tissue and open up the channel that way. It also requires a general anesthetic. It has a very comparable retreatment rate of 5% within 5 years and has a lot of the same side effect profile as we've discussed. Again, showing similar slide to what I showed before, it accomplishes a very similar thing by opening up that channel. And ultimately, prostatectomy or suprapubic prostatectomy, where a portion of the prostate is actually physically removed by making an incision. This is most commonly done now through a robotic approach, through multiple small incisions, but can be done with a larger open incision. And a portion of the prostate is physically removed. This is typically done for very large prostates that would not be amenable to some of these more minimally invasive approaches that we've discussed. Of course, this requires a general anesthetic. The surgical retreatment rate is very low. The potential risks are definitely higher with this procedure in terms of bleeding and possibly the need for transfusion, as well as some sexual side effects. I'll skip over the insurance coverage because that's something where our office staff would help to make sure that what you decide to do is appropriate for you. So, in summary, we talked about the prostate, we talked about what it is, the importance of it in terms of its relationship to BPH and enlarged prostate with urinary tract symptoms. We talked about some treatment options ranging from the least invasive all the way up to the most invasive options for surgery, as well as the first line therapies like medications and the minimally invasive approaches. So, the important thing is really undergoing a thorough evaluation with your urologist, trying to figure out what's the appropriate option, what's the appropriate treatment for you as an individual, what your expectations are, what risks you're willing to take, and really what's going to be the right choice for you. And with Arizona Urology Specialists, there are a number of us that are well versed in all of these modalities and would be able to help you figure out what is appropriate for you. Hopefully, we've been able to review the prostate, BPH, and some of the treatment options that are available. Myself, the other physicians, Arizona Urology Specialists, would be happy to see patients and review what options might be appropriate for them based on their evaluation. I would encourage men, this is a very common issue that may or may not be discussed with their family or friends, but it's something that we see every day. And if it's something that's bothering you, we have a lot of good options that are out there. Thank you very much for joining, everyone. I appreciate it.
Thank you, Dr. Steinway, and thank you all for joining us this evening. You can view this video presentation and a full catalog of other videos on Arizona Urology Specialist YouTube page. Dr. Steinway is seeing patients by telehealth and in the office. And for more information or to schedule an appointment, please call Arizona Urology Specialists at 480-661-2662 or visit our website at arizonaurologyspecialist.com. Thank you so much and have a great evening.